We are at our number 2, second webinar in our series on aging with HIV since birth, and we are discussing the journey of women lifetime survivors. This this session is focused on sexual and reproductive health among women and lifetime survivors, and I have some amazing folks here with me that are going to do our presentation for us. Jenna, let's go to the next slide. And I'm going to move through these pretty quickly. This is our second time together, and all of the slides will be available via the recording once we're done. So if you're not familiar with the WELL Project, we are a nonprofit that focuses on women and girls, and our mission is to change the course of the epidemic through a unique focus on women and girls living with and vulnerable to HIV. And the WRI, the Women's Research Initiative, which is what is bringing us here, is one of our programs. And we are a multidisciplinary and multi-sectoral effort dedicated towards identifying gaps and recommending solutions around research and policy. And I think we do it pretty well. Next slide, Jenna. And so an important note on gender and language, and I do want to highlight this. The WELL Project has long, since its inception, advocated for the importance of gender and language. And so our programming focuses on women across the gender spectrum who identify as such. A rose is a rose is a rose. And so if you identify as a woman, we are a welcoming space. We also celebrate and uplift the existence of our community members who are of trans and non-binary experience, and that is so important right now. And we encourage the use of first-person language always, and we discourage, obviously, the use of stigmatizing language. Next slide, Jenna. So your presenters today, I am Bridgette Picou. I am the stakeholder liaison for the WELL Project. So I'm a nurse by trade, an advocate by work of heart, and all things HIV related are where I intersect. We have the amazing Kim Canady from Conversations with Kim, and she is one of our Dandelions, one of our lifetime survivors. So we're pleased to have her here. Kate Powis is an amazing MD researcher, all of the things. We love working with her. And finally, we have Amelia Stanton. Amelia is from Boston University. This is our first time working with her, but we already love her, and I think that you all will as well. So welcoming them, virtual round of applause. And so today's session is going to center our presentations first. It'll be conversational style, and then we're going to have our Q&A. At the time that we start into the Q&A, all of the panelists, you'll get a little prompt to be promoted to, all of the participants will get a prompt to be promoted to panelists. This is how you'll be able to come on camera and ask questions if you would like, or unmute yourself if you don't want to come on camera and ask questions. As we go through the presentation, I encourage you to please ask questions in the chat or in the Q&A so that we can have those and we can jump right into them at the end. While the webinar is being recorded, and we will make the webinar publicly available, we will not be making the Q&A or the chat publicly available, and that is to protect folks' identities, for you to be able to speak freely without fear of reprisals. So please keep that in mind. And then we'll throw up a little QR code for a very short, we have shortened it, evaluation at the end. And so with that, next slide. And these are some of our resources. Again, they will be available with the recording, or you can just reach out to one of the staff members here at the WELL Project if you have questions. And next. All right. So we are going to get ready to jump right into our presentation. I have seen the notes. You're in for a treat. And as we get the slides up, take a breath. Get ready. I hope that all of you are centered and feeling good about where you are in your bodies today, and where we are in the world is not an easy space, but we have each other, right? So we're covering sexual health and reproduction. And our theme is that life does not pause for HIV, right? And so we're going to cover living with and treating HIV for a lifetime. That was our first webinar. Today we're talking about sexual health, sexual and reproductive health. And then our next webinar, which we want to make sure that you tune in for, is going to be accelerated aging and HIV comorbidities among lifetime survivors, which is a unique take, right? All of this is. And so with that, I'm ready to turn it over to our amazing presenters.
Hi, everyone. It's lovely to be here. This is an esteemed group I'm learning, so it's really great to be part of this process and part of this webinar. We are going to be talking to you about sexual and reproductive health today from a variety of different viewpoints and stages, recognizing that this is most certainly a life course issue. So there's so much here to learn about, and sexual and reproductive health have lots of different component pieces. We're not going to be able to cover all 6 of these elements today because we would be here for hours and hours and hours. But we will cover certain aspects that we think receive either relatively less attention or aspects that the 3 of us are experts in, so that we can offer you our perspectives and certainly learn from you as well in the Q&A. So today I want to highlight a few areas that we're really going to be focusing on. One of which is contraception and family planning, item 2 there. Kate is going to do a lot of coverage on that later in the talk. I'm going to be talking quite a bit about some of the research and sort of thinking around sexual health and pleasure specifically, since that's an area that we don't talk about so much in research when it comes to women living with HIV, lifetime survivors. And Kim is going to provide the really grounding experience of her lived experience and how it relates to all of these different components. And that's going to be really essential here. So I think we can transition to the next slide. Yeah, so sexual and reproductive health is a pretty broad concept here, and I'm going to read this to you just so we have a moment to pause and think about this definition. This is a state of complete physical, mental, and social well-being in all matters relating to sexuality and the reproductive system. It includes the ability to have safe and satisfying sexual relationships and to decide if, when, and how to have children, and to access the information, services, and care needed to support these choices throughout life. Importantly, especially historically, a lot of our sexual and reproductive health research has focused on disease prevention and infection control. And I think that has been a really big part of the work that we do from an intervention perspective. I do a lot of work in intervention development and implementation. We're trying to mitigate risk. But the other side of this issue and this definition that's really important is that we want people to have safe, satisfying, pleasurable sexual lives and relationships. And I think we need to balance both the positive aspects of sexuality with these other aspects around prevention and ensuring that we are protecting ourselves and others. Next slide. So importantly, we really view this from a rights perspective, and we understand sexual and reproductive rights to be human rights, and core principles being bodily autonomy, right? The decision that we make, the many decisions that we make about our body, how and when to use our body, how and to engage with our bodies, and not have others controlling those decisions for us, especially for women who are born with HIV, right, who did not really come into this later in life, who really, this is their entire worldview, at least from the get-go here. We also view healthcare access and access to really high quality healthcare with respect to family planning, maternal health, comprehensive abortion care, all of these elements as fundamental rights as well. And with that comes also this freedom from violence, this idea that we are protecting from all forms of sexual violence, coercion, and harmful practices that do have negative impacts on sexual pleasure and autonomy. Okay, so the rights that we affirm, right, the rights that we just talked about, autonomy, access to healthcare, freedom from violence, we can articulate them, we can talk about them in theory, but really the realities that we navigate may look a little bit different. They may be experienced in different ways than sort of just like writing them down on paper and what we can read here on this slide. So they are navigated through everyday realities and experiences. And I want to turn it over to Kim to talk a little bit more about those from her perspective.
Thank you, Amelia. Can we go to the next slide? So, at every stage of my life, HIV was there. It was there during childhood, adolescence, dating, marriage, and now aging. I wasn't becoming a woman and then later adapting to HIV. I was learning both simultaneously. So, as a lifetime survivor, our experiences are unique because HIV wasn't an interruption to our sexuality. It was part of how we learned about ourselves from the very beginning. Next slide. So disclosure is one of those things that is never just one conversation. People often think disclosure is, I'm just telling my partner. But for me, disclosure, I'm not just worried about disclosing about my status, it's also disclosing my parents' status. I'm disclosing whether what's going on in my household. Disclosure is a lifelong process. So I've disclosed to friends, family, healthcare providers, partners, and eventually to the public through my advocacy. And every relationship required me to decide, when do I tell? How much do I share? Can I trust this person? Which is a really big thing that sometimes it's a hit or miss. Will they stay? Will they leave? And sometimes disclosure has brought connections and acceptance. Other times it brought fear, uncertainty, and vulnerability. Me learning through the process is that disclosure wasn't really about revealing HIV. It was about deciding who has earned access to my story and to my life. So when we think about disclosure, we got to think about, again, it's not just me, it's everybody that is in my circle, everybody that is around me, that comes with this complexity of having to disclose or wanting to disclose and what that looks like. Um, so talking about disclosure, Amelia, can you just tell us a little bit more about the various components of sexual health and well-being, and what that looks like?
Yes, of course. So, a model that I've used a lot in thinking about some of these components is the sexual health model or sexual well-being model that we've had actually in our repertoire and our toolbox for quite some time, a little over 20 years. And this model, I think, is really comprehensive and gives us an idea of all of the different components that go into this very multifaceted construct. So from talking about sex, right, disclosure, as Kim was highlighting, to culture and sexual identity, thinking about body image, positive sexuality, spirituality, all of these components are really important to this overall picture. And living with HIV as a lifetime survivor, right, that status really infiltrates into many different components, not necessarily all of them, but into many of them. And so when we think about sex, it's really not just about, right, disease prevention, transmission, et cetera. It's all of these other components, especially from that lifetime survivor perspective. And I'm going to talk a little bit here about sexual pleasure and well-being as a really important aspect of this model and of living with HIV. Oh, next slide, please. Yeah, so first, before doing that, I just want to sort of highlight the unique issues that we talk about among lifetime survivors, which Kim will elaborate on and will continue to tell us more about over the course of the talk. But as she mentioned, right, individuals who acquire HIV later in life have this sort of disrupted sense of the pre-time and the after-time, versus lifetime survivors have really never experienced sexuality outside of the context of HIV. So that status sort of infiltrates all of these different component pieces. And, you know, for some people, not for everyone, but for some people, you know, sexuality develops in the context of a really highly stigmatized condition that is present from childhood onward. And there's a lot of uncertainty about how people respond, as Kim said, right? A lot of confusion, a lot of anticipation about this disclosure element that really does impact how we experience sexuality, sexual pleasure. So it's not just this reproductive health issue that we talk about in terms of sort of the medical pieces and the data. It really is entwined with identity development from the get-go, with building relationships initially throughout different phases of life. This disclosure element really impacts all of those things, and in turn can impact mental health, quality of life, all of these other elements that are really important for sex and sexuality. Absolutely. So perhaps now we could transition back to Kim to tell us a little bit more about sort of what messages she heard about sexuality growing up. As a lifetime survivor, what was she hearing? What was she engaging with? What was she conceptualizing about sex and sexuality?
So thank you, Amelia. I want to just read out this quote real quick. Before I learned about desire, I learned about danger. And that shows a lot about growing up with HIV, what that looks like. For me, I grew up in a very religious household. So it was less about the danger aspects of HIV, but more so keep your legs closed and do not bring a baby here because Jesus, okay, he will get you. So it was more of that growing up in my household. But outside world, when I'm at the doctor or I'm with other people, growing up looked like heard about protection and responsibility. And that's a lot to conceptualize as a child about it's my responsibility when it comes to sex, and what that looks like to disclose or even just what that looks like for the other person because all the weight falls onto me. And learned about what medications are, learned about transmission, learned about just being careful and what that means for me with my partners. And not even just my partners, but even being so scared that if I cut my finger as a child, and playing with other people, what that can look like. But I didn't hear conversations that I wish they had about joy, about desire, about intimacy, or even just about pleasure. So for many of you, I know I'm a pleasure activist. I talk about pleasure when it comes to sex, but I also talk about pleasure when it comes to just your well-being as an everyday person and what that looks like. Because that's something that when it comes to HIV, we do not talk about. We don't really dive into the pleasure aspects of life. So nobody ever said to me that you deserve a healthy relationship. And that could be because a lot of people around me didn't have healthy relationships. No one said your body belongs to you. No one said you were worthy of love and pleasure. So much of what I learned centered around survival and not thriving with HIV. And that survival aspect really plays a part when you are conditioned and taught as such a young child that you can be a danger to somebody and never to really think about what does joy and love look like. Um, so I would love to hear more from Amelia on more aspects of about sex.
Yeah. So when we talk about U equals U, and the way in which this really transformed how we think about sex, in the context of HIV, how we think about pleasure, we really started to see some clear patterns in our data once the messaging that when you're undetectable, you can't transmit the virus to potential partners. Once that started to get out and was really framed in this U equals U way, we saw reduced anxiety about transmission. We saw improved sexual confidence, increased senses of intimacy with partners, and greater relationship satisfaction. So it's not just the biology, right, of this reality of this kind of wonderful piece of data that we started to consistently talk about and frame in this way, but it really is the satisfaction, the intimacy, the pleasure, the increased ability to engage sexually without this concern about transmission, which of course you can imagine, right? If you don't have that anxiety while you're engaging in sexual activity, it might be more pleasurable, it might be more enjoyable, and that makes really good sense. Yeah. So this really lovely notion, data-based, and then interpreted in a really, I think, very lovely way as a larger mental health messaging platform that for women living with HIV, we can have like these healthy, pleasurable, enjoyable sexual experiences and not worry about transmission. How did that sort of manifest for you, Kim? I'm curious. Is that messaging something that you thought about or you engaged with, or did that shift anything for you?
So you equals you. So as a first gen child of HIV or baby born with HIV, back in the like I'm I'm not afraid of my age. I'll be 40 this year. So for us, very proud that I hopefully I don't something else don't happen. Like I get hit by a car. I always say HIV is not gonna take me out. It's gonna be something like a car and I don't got my glasses. Um, but growing up, our doctors were onto something. They were telling us like as long as you take your medicine, you do not have to worry about passing on HIV. So at that time, it wasn't labeled you equals you. They were telling us, make sure you take your medicine. You're protecting not only yourself, but you're protecting your partner as well. So we had this messaging. Again, it just didn't say you equals you. But you equals you now because we have a nice little phrase to put it up with of what we already kind of knew growing up is it reduced the fear. It increased confidence. It gave many of us hope. So many of us who didn't get that messaging from our pediatricians, um, it's now like a symbol where we can actually have a conversation that is backed up by science, that is approved, that we can tell our partners, like, no, as long as I am undetectable, I am untransmittable. But the science alone wasn't something that healed me. It was healing also required trusting myself and that internal stigma when it comes to you equals you. So for me, I didn't have, it took me a really long time for me to not just trust the science, because science was ever evolving, it was ever changing, but to also trust me and my HIV, to trust that, I have the confidence to own my body, to own what's going on in me, to forgive not just my parents, but also to heal that little part of me when it came to wanting to have sex, releasing guilt. So for most people, they think like, oh, what do we feel guilty about? But again, you hear it was nothing but negative messaging when it came to HIV, and then wanting to now tell somebody else at like 15, 16, like even wanting to kiss somebody. That was a scary thing for me because of the messaging that I had got. And believing that I was worthy of love, knowing that an intimacy and even just connection when that wasn't something that I was hearing. So science gave me the information, but healing helped me believe that I am worthy of love, that I am somebody who, you know, can actually believe in what you equals you was saying and what the science is saying that, can be a thing. But when I think about that, I know we're going to be talking more about sexual function, and I would love to hear again. Amelia, I know we bouncing back, and Kate, we're going to get to you real soon. So it's not just an Amelia and Kim show. But Amelia, can you tell me a little bit more about like what does sexual functioning look like, the biologies of everything?
Yeah, so I do and have done quite a lot of research on vaginal blood flow and sort of the specific sort of physiology of how sexual function works for women. And yes, when we engage in sexual activity or are interested in engaging in sexual activity, we do have some physiological changes that are pretty notable. And those include lubrication and, dilation of pupils, hardening of nipples, increasing heart rate. A lot of these physiological changes happen during sexual activity or in anticipation of sexual activity. And other physiological changes happen too as we age, right? We have reduced lubrication, thinning of vaginal tissue due to reduced estrogen. And yeah, that's the biology of how sexual function can work in the body. But there are other key factors, huge other factors that are really important when thinking about sexuality and sexual engagement. The psychological factors that come into play, right? In a lot of our diagnoses, we have decreased libido as a symptom or a consequence of some of these disorders. And certainly factors like internalized stigma, how we think about ourselves, how we think about our bodies, those things impact how we respond sexually. Relational components are huge. A lot of our work has demonstrated that, especially for women, there are these contextual factors, right? Men, we have especially like an appendage that rises during sex, and there's a lot that we can point to and say, okay, yeah, that's arousal. But for cisgender women especially, there's a lot of this sort of component of what's going on around me. What is my partner offering? What are they taking? What are they engaging with me around? And how are we communicating about sex? So communication for sure is a really important element too. And these structural factors cannot be ignored when we're talking about sex and sexuality, especially in relationship to HIV. There's a lot of stigma that comes from the structures and systems that we engage with, certainly gender inequity and access to care. So all of this is really part of our bigger picture. That's why we have this model that we introduced earlier that addresses some of these components here that isn't just like how we experience sex in our bodies and the physiological changes that happen. And I say that because these factors all influence pleasure and satisfaction. And for women, what we see is that these components can really have a major negative effect on satisfaction. And when we increase pleasure, when we have more satisfaction in a sexual experience, we see corresponding changes in these other domains. So among women living with HIV specifically, increases in pleasure and satisfaction are associated with broad other stuff, better quality of life, less depression, better relationship functioning, greater self-esteem. So pleasure matters, right? Pleasure isn't just this thing that we'd like to have as a tertiary outcome. Like it really does matter for our lives, our well-being, and especially for women living with HIV. And the flip side of that, of course, is that these really HIV relevant components like HIV specific stigma interfere with pleasure and lead to some of the things that Kim was describing, right? Rejection, fear of transmission, guilt was a big thing that she highlighted during sexual activity, and difficulty being emotionally present during sex. So if that's on deck, then we're not getting these pleasurable experiences. We're not getting these other aspects of sexual function, the core domains like desire, arousal, orgasm, and satisfaction. Or maybe we're getting that, but in reduced quantities. And in general, right, that's really important when we're thinking about what interventions work for women. It's not just the things that target, reduction in the bad stuff. It's the interventions that give us a sense of joy and tell us that sex is good when it feels good, right? Okay. We also know that pleasure matters in the context of relationships. And in general, we see sexual satisfaction scores go up in relationships when there is a high level of intimacy, when partners trust each other, when there's a sense of emotional connection, and when there's shared power, right? Pleasure just doesn't go up when we have more sex. Pleasure doesn't go up when one person is having their needs met. Pleasure goes up when we have this sense of intimacy, this emotional connection. And among women living with HIV specifically, we see that pleasure and satisfaction are strongly linked to relationship quality, to that trust that can be built within these relationships. And when we change communication or improve communication styles within couples, we also see related changes in sense of agency, disclosure confidence, and relationship satisfaction. So those elements are really important in relationships too. And a lot of the work that I do and I talk about a lot with my colleagues is that pleasure is also a public health matter of urgency. So pleasure isn't just making women feel good, isn't just making their relationships better. It actually helps engagement in care. It increases engagement in care. And that's really important. And some people much smarter than me have been talking about this in the past 5 to 10 years, how really the interventions that do focus on pleasure have better outcomes, sexual health outcomes and engagement in care outcomes. So HIV, as I've talked about, as Kim has mentioned, has often been framed in terms of risk, danger, transmission, and if that's all we focus on in our interventions, they're not as effective. So in turn, we see that pleasure-focused approaches really do lead to the engagement and care stuff that we want to see. We want increased adherence to ART. We want some of these outcomes and reduced shame, improved communications with partners. When we have more pleasurable sex, we could talk about those experiences more with our providers. We have less shame about communicating about sex with providers and about talking about reproductive goals. So pleasure-centered care certainly doesn't replace risk reduction or, prevent those conversations about transmission, but it does really broaden the scope of care to support all of these really critical elements: thriving, health, having fulfilling, meaningful lives, especially intimate lives with partners, and with other forms of relationships and other people that we want to be intimate with. Yeah. One nice example of this, I think, is a somewhat recent, now a few years old, study that came out of a group in Canada that really sort of created a tool to talk about pleasure among women living with HIV and lifetime survivors. So this was a user-generated platform that is still running today. I double-checked, and people are still communicating about what pleasure means to them and how that looks in their relationships and what sort of this radical focus on pleasure might look like. Let's talk about masturbation. Let's talk about how to engage with each other in ways that feel really good. What does fulfilling sex look like, rather than just more frequent sex or sex that doesn't hurt as much or more safe sex? So a lot of folks have contributed to this website, and it'd be great if you guys take a look at it. But it's a really nice way for people to come together and talk about pleasure and why that matters. Okay, so having spent some time talking about this from more of a research perspective, Kim, I'm hoping that you would share some of your experiences about sex and intimacy and how that manifested for you.
Yay, the fun stuff. Okay. So for me, like I said, I grew up very religious. For those, again, who is known as no Pentecostal households, it was very, very strict. So my messaging between living with HIV since birth, back in, I want to say, I was born in 86. So by the time we were really talking about sex, which wasn't really talking about sex, because again, the household that I grew up in, this is like 96, 97, right? And then as we're growing up with little to no real information on HIV, and then put in the aspects of me being a Black woman living in the hood, and really access to education wasn't something that was just being thrown out there when it came to the little bit of information that we had. The messaging was, again, fear-based. It was fear not just of HIV, but fear of rejection, right? Will they see me as a woman? Will they see me as somebody who is more than my HIV? I remember hearing stories of my friends and them telling people, and then we had to then worry about fear of violence because that person were then now attacking them and they're like 15, 16. So for me, it's that added on of, okay, are they going to harm me? Will they view me differently? For a long time, that guilt carried on of, I didn't want to pass that on, because even though we had the science, we had the information, what does that look like when I tell somebody? Are they going to accept me fully for who I am? So now I caught myself being an educator, teaching them before I even disclose, which then puts it even harder for me as somebody who's already living in fear of what's going to happen, of the unknown, and then now having to want to even just trust my body and trust that they won't, harm me in any way. And then the emotional part of it, because just being in a relationship and then opening yourself up puts on a whole nother sense of things of what that looks like when it comes to just disclosing and having sex and being intimate. Because being intimate is not just about that I'm touching your body parts and you touch your mind, but it's really about, I always say, into me, I see. So you're looking into me, I'm looking into you. We're learning more about each other. And then that's another vulnerable part that I have to be now opened up for you to possibly get rejected. And that alone, on top of being HIV positive since birth, it's layers upon layers upon layers of just already complex trauma that we're already dealing with. And now trying to figure out how does that look like when I'm now getting naked with you? Are you gonna judge me? So it's a lot of stuff that goes with that. Next slide. Uh-oh. One moment. Okay. So as we were just talking about like some of the things that were the hardest part of like learning to believe that I desired intimacy and that that wasn't something to be feared, right? And y'all heard about me and heard about a little bit about what's going on in my world. As I'm talking, I want y'all to get your phones, go to the Mentimeter, scan that, and then the question for y'all is, what do you wish people ask you about in terms of sex, relationship, and having children? All right. So again, the question is, what do you wish people ask you about in terms of sex, relationships, and having children? So if you can get your phone, you can scan the little barcode, and then you can pop in your answers right there. And I see 1 of 14 responded. And we're waiting for more. We got 2. And you can also go to menti.com and input the code. Bridgette put it down in the chat as well. So as they're coming up, I can read them if I can see, because these glasses ain't glassing the way they need to glass. If I was having pleasurable sex, how did having children change your sex life? How do you define pleasure? What are your desires without judgment? What makes you happy? That sex was not only about risk or taboo, but also should include pleasure, joy, connection, and overall health and wellness. Does it feel good? Baby, if somebody would have just asked that question, does it feel good? And what does good feel like? That would have been a good question. What would be ideal for me? Instead of when are you having kids, ask, are kids in your future plan? And another one is, how did you overcome stigma and barriers to having children? And I'm gonna read this last one, that I wasn't fast for thinking about sex. That part, that it was a natural thing, that it was something that just came up, that something it's a part of biology, is a part of physiology. We miss that part when especially in specific households where it's like, you a fast girl, you doing too much, or having more than one sexual partner means that you are a whore or a hoe. When Jasmine Sullivan is talking about hotels and is telling us that we need to be busting it wide open. Sorry if this is going off a script. But yeah, we need to be doing that and being enjoying it and having the sex and getting touched and touching them and feeling our bodies first to know what that looks like and what that feels like. So that way we don't have somebody else telling us what feels good. So these are thank you for jumping into the Mentimeter. Go to the next slide. So growing up, some of the questions that nobody asked me is, when do I tell somebody? Like, will anyone love me? What if they reject me? Will I ever stop feeling different? Again, can I have children? Do I deserve pleasure? So a lot of these line up, in some kind of way. And I think that that's one of the things where we all are common when it comes to talking about sex, when it comes to growing up and wishing that we normalize these conversations, even though I know we're doing it in having this webinar, which is something that most people think is untraditional. But if we had webinars and we had conversations like this to normalize not just about sex and pleasure, but also about HIV and growing up and what that looks like, I think that the world would be a much happier place because maybe people will be having a lot more orgasms. That's a whole nother thing. But it would be less confusing and people would be less angry, honestly. And then we wouldn't feel alone, like we're the only one on this journey trying to figure this out. Next slide. So yes, so questions that came. Where am I? There we go. So the questions that came first, will anyone love me? Thinking about that is like, I know I shared my experience and it's great to have this platform to share, but as historically shows, like our voices were not sought out or heard, right? And for many of us, when it comes to not even just many of us, as lifetime survivors, our voices wasn't in research. Um, Studies like the Hope study where we have Kate, and this is where Kate is going about to shine, right? Where it really took a moment to like really look into our community and have the data to share about sexual and reproductive health of lifetime survivors is something that, you know, I wish could have came a lot earlier, right? I wish that people really did take that time to really think about what is our needs instead of putting us together in a box with everyone who is living with HIV, because we do have such unique needs and just like attributes to who we are. So right now I'm going to pass this over to Kate, and I would love to hear more about the Hope Study background and everything that Kate has to offer.
Thanks, Kim and Amelia. This has been such a good discussion, and I'm really looking forward to hearing others' thoughts as we move into the overall discussion section. But I wanted to go through some data that we do have about lifetime survivors. And one of the best studies that I'm aware of is one that I'm involved in, and a shout out to Deb Kasanik, who helped prepare the data that you're going to be looking at about the Hope study, and Kimberly Saunders, who's also on the call, who's one of the leads of the Community Advisory Board for the Hope study. Hope study was a longitudinal study of health outcomes of women of reproductive age living with HIV in the US. And we didn't intend specifically to look at lifetime survivors, but with over 10,000 persons who are lifetime survivors in the US, invariably, when you conduct a study in 14 clinical sites across the US, we're going to get some lifetime survivors. The way we conducted this study is an enrollment visit initially, where interviews were conducted, online surveys were taken, and we did medical chart abstraction. Thereafter, annually, online surveys were used for virtual visits, and we continued chart abstraction. A total of 856 women were recruited between April of 2022 and June of 2025, 30% of whom were lifetime survivors. In order to get into the study, so you have a sense when you look at the data, participants had to be female, sex at birth, 18 to 45 years of age at enrollment, have a documented HIV status, and able to communicate in English, Spanish, and Haitian Creole. This is a study that was funded by Eunice Kennedy Shriver National Institute of Child Health and Human Development, and heavily supported and reflective of our Community Advisory Board. And once we established a solid Community Advisory Board, we added a Spanish-speaking Community Advisory Board, which I think is very important. So let's take a look at some of the data. We'll start with contraception use. And so this was asked of women who reported being sexually active. And notice the maroon rectangle around the youngest population. What we can see here is among 251 lifetime survivors in the purple column, 46% indicated that they were using some form of contraception, compared to 73% of the younger individuals with HIV acquisition later in life. Key takeaway there, in the Hope study at least, among young lifetime survivors, 18 to 24, contraceptive use was significantly lower compared to women who acquired HIV later in life, that 46 versus 73. Next slide. So we thought it would be important just to break out and focus on that 18 to 24 group and think about their pregnancy intention. Maybe it's because they don't plan to get pregnant, or they were planning to get pregnant, and therefore they weren't using contraception. And so when we asked about self-reported pregnancy plans with options of, I don't plan to get pregnant, or sure, I'm going to get pregnant within the next year. And those are people who may not be using contraception versus, yes, I want to get pregnant, but more than a year off. And those who didn't know. If we look at the 59 lifetime survivors who responded, we can see that 31% had no plans to get pregnant versus 16% of lifetime of individuals who acquired HIV later in life. And that's kind of a disconnect with the contraception response. And Kim and I were talking about this earlier in the week. Go ahead, Kim.
I was like, do I just jump in? Do I ask So one of the questions that I had was, for younger lifetime survivors, is it because that they just didn't want to take another pill? So I know for me, it was like, for me, I was on all the pills, but that was because I'm really controller. So for me, I wasn't on medication, so taking birth control was fine. But for others, just taking another pill every single day, could that have been a barrier?
Yeah, and we did, it's a really good point, Kim. We did ask this of HOPE participants, and that was, I didn't look at this specifically. I didn't think ahead of this to look at this specifically, but a number of people, not so much young age driven, but a number of people did indicate that they just didn't want to take another pill. I think the other thing historically is there was a time period when some contraceptive methods were considered maybe to be ineffective with the use of certain ARVs, and that may have driven it. But this was all done between 2022 and 2025. So it's a really good point. And I think it raises, as we look at data, it's so important to have a discussion of what does it really mean, as opposed to these are the numbers. We've got an answer here. But overall, key takeaway, 18 to 24-year-old young lifetime survivors were more likely to report that they didn't want to get pregnant, 31 versus 16%. But if you look at it, only 9% of the individuals who acquired HIV later in life were expressing a desire for pregnancy now in the younger age group, none of lifetime survivors. So next slide, and let's move on with intendedness of pregnancy. Again, thinking about that contraception issue, this is asked of individuals who have had a pregnancy. And the question was your last pregnancy intended? And what we can see here, a flip side of the youngest group, 40% intended the pregnancy that occurred versus 5% of people who acquired HIV later in life. So even though they're not using contraception, the pregnancy they experienced was intended. So substantially more likely to report that their last pregnancy was intended among the youngest lifetime survivors compared to those who acquired HIV later in life. And differences in pregnancy intendedness were less pronounced at older ages. So there is a clear difference in age groups between lifetime survivors. I will caution you that we obviously don't have as many, even though Kim mentioned that she's 40, she only looks 20. We didn't have as many lifetime survivors in the older age groups. So next slide. Pregnancy outcomes, a little bit of data here from two different cohorts, a Brazil cohort of 186 women, older, dating back to 2006, so some of the older regimens up to 2019, 54 lifetime survivors included in that cohort, and reassuringly, no statistical difference in preeclampsia, fetal growth restriction, fetal loss, preterm birth, or low birth weight, compared to women who had acquired HIV later in life. When we look at a London cohort, 2015 to 2022, much smaller in size, only 19 lifetime survivors, 17 who acquired HIV later in life, but importantly, a comparator group of persons who didn't have HIV, And we see that the preterm birth rate is highest among the lifetime survivors. A little bit different than what was seen in the Brazilian study. Small for gestational age, the child having a lower birth weight than would be expected for their age, gestational age at birth, was again higher in lifetime survivors compared to women who did not have HIV. So evidence regarding pregnancy outcomes among HIV lifetime survivors is limited. Existing studies are small and often underpowered, making it difficult to interpret and highlighting the need for larger prospective studies in lifetime survivors with appropriate comparator groups. So this isn't specific per se to lifetime survivors, but I think we ought to put it out there because it's a very important evolving space in terms of infant feeding choice. Between 2023 and 2024, several U.S. advisory groups revised their recommendations regarding infant feeding, previously saying that all persons living with HIV should formula feed, and now it's moved to a shared decision-making. Now, this has happened predominantly because science has shown us, like the U equals U, that the risk of transmission is less than 1% in any person who achieves sustained viral suppression. The UPLIFT study, which is part of the IMPACT network, IMPACT being International Maternal Pediatric Adolescent AIDS Clinical Trials, is a study that's being conducted in the United States that's really looking at the implementation questions about this, because although the guidelines changed, there still were a lot of questions. For example, what if when I deliver, my breast milk hasn't come in? Does that preclude me from being able to eventually breastfeed? What do you do in terms of giving the infant antiretroviral prophylaxis? Is that for a limited period, or do you need to do it throughout breastfeeding? What if I do practice misfeeding both breast and formula milk? What kind of clinical support do I need when I transition from my obstetrician to my pediatrician to my HIV care doctor as an adult? How often should an infant be tested? How often should mom's viral load be tested? So UPLIFT is really engaging pregnant and postpartum women with HIV, healthcare providers, and the ancillary healthcare professionals like lactation experts and persons who might influence a woman's infant feeding choice, a partner, family members, to generate evidence that supports both informed infant feeding decisions and the approach to do this that makes sense. So we've moved literally from can women breastfeed to how do we best support women who choose to breastfeed? And this is a great space for lifetime survivors, as well as any postpartum person who wants to make a full informed choice about how to feed their infant, even a pregnant person, because the discussion has to start there. So what does all of this mean? How do we pull it together? We can see that pregnancy desires, particularly in the HOPE study, were diverse. There's lifetime survivors don't share a single reproductive goal. Some desire pregnancy, some want to avoid it, some just don't know. Reproductive counseling, and I think you heard this from Kim, reproductive counseling that's positive and not shameful, not blameful. Conversations need to begin early in adolescence and continue throughout adulthood, because you know, HOPE is a cross-sectional study. We took a point in time. People's desires around having children are probably going to change over time, and those conversations need to continue. And then ultimately, and while we didn't cover all of these areas, it goes back to Amelia's sexual and reproductive health rights, supporting autonomy and informed choice. Clinical care really needs to empower women to make informed decisions about contraception, about pregnancy, about abortion care, infant feeding, and healthy aging. We'll look at a few other data points. I know this isn't as exciting as Kim's life experiences, but we'll get back to Kim. So let's just look at STI data. This is with 50% of new STIs are really occurring in the US among the youngest population or youth, 15 to 24. Chlamydia, gonorrhea, syphilis, trichomoniasis. And if we look at data from the Adolescents Trials Network, ATN, where they combined 3 different studies, including 888 youth and adolescents, 20% of whom are lifetime survivors, what we see is that much higher rate of STIs or sexually transmitted infections among individuals who acquired HIV later in youth. That may be because HIV and a sexually transmitted infection go hand in hand. It's hard to say with this data, but this is what was reported out. So overall, female youth lifetime survivors had a significantly lower rate of sexually transmitted infection compared to those acquiring HIV later in life. And it speaks to the need to make sure that targeted age-appropriate sexual health services are essential for all youth living for HIV, but it may look a little bit different depending on when you acquired HIV. If we then look at, again, back to HOPE data, again, this is not youth, this is spanning from 18-year-olds forward. And we asked about self-reported STI screening. And what we can see here is that among the youngest age group, lifetime survivors were substantially less likely to report STI screening compared to women who acquired HIV later in life, 48% versus 82%. And even though those differences are less pronounced in older ages, up to age 39, lifetime survivors less likely to report that they're screening for STIs. That may be because they're not sexually active, but it may be that they're not getting asked about risks or offered STI screening. I also just want to interpret that data because the ATN data looks a little bit different from the HOPE data. Both lower STI incident and higher STI screening are important goals for lifetime survivors. And that difference may be explained by differences in sexual risk profiles between youth and the older women who participated in HOPE study, differences in sexual behavior and partnerships, under-screening among lifetime survivors, barriers to sexual health engagement, or any of these. Maybe the next slide. And I'll shift at this point to cervical cancer screening, just for more data points. So this is the guidelines for the US for women living with HIV. And we can see basically that for lifetime survivors, their initial screening should happen with their first sexual debut. And here, it doesn't refer to them as lifetime survivors. It indicates that if they acquired HIV before age 21. Repeat screening should happen 12 months after that. And then persons with HIV require or should have more frequent screening than a population of individuals without HIV. But there's really no defined difference in screening whether you're a lifetime survivor or acquired HIV later in life. And so that's probably something that needs to be looked at in more detail. Again, in the HOPE study, we asked about cervical cancer screening in the past 12 months, and self-reported screening within the past year was suboptimal across all of the age groups, regardless of timing of HIV acquisition, but much lower, 32% in lifetime survivors in the youngest age group versus in the younger age group, those who acquired HIV later in life. So it's a big opportunity there. Next slide. So I gave a lot of data. You may have fallen asleep. This is time to wake up because Kim's going to be back on in just a minute here. But what gets measured isn't always what matters. We talked about STI rates and cervical cancer screening. Often we report out viral suppression and pregnancy outcomes. But what women experience is equally as important. And research often measures health outcomes, but women live human experience. And we really need to understand sexual and reproductive health among lifetime survivors, both blending that epidemiological data with that lived experience. So Kim, I want to turn it back over to you and have you react to some of this and your lived experience.
Thank you, Kay. So just a heads up, guys, we are wrapping up. We're coming home, okay? Just so everybody knows. So pleasure was a part of my healing. So when, oh, Jesus. So most of my life, survival was the goal, right? And I know that it wasn't just, I'm speaking from an I statement of myself, but I know a lot of us have different conversations together where it was like, take the meds, go to the appointments, all 8,000 of those appointments, from it being, again, me being first gen, appointments were like once every month to then every 6 weeks to then every 3 months, and then do what you're supposed to do, protect the other people, stay healthy. And while all those things matter, all at some point I realized surviving and actually living are two different things. It didn't really hit until, again, I lost a whole bunch of people and I realized, like, am I even living? I'm alive, that was the goal, but nobody taught me to actually enjoy life, because that was something that I didn't think that was going to happen. Nobody taught me about pleasure. Nobody taught me that I deserve joy, to feel good in my body. Like, I was taught that my body was a danger, and not just as living with HIV, but also just being a woman. It's like, don't get pregnant. Like, trying to get out of that survival mode is a real thing. And even as I'm getting older, um, hearing those messages, seeing it on TV, messages about risk, transmission, responsibility. And that big responsibility piece plays a big part, because it's not just, we carry that with us as we're getting older, and you're learning that you're responsible for not just, again, I'm a mom, right? Which I'm going to talk more about in the next slide, but I'm always having to be responsible for not just me, but also for my child, for my husband, for everybody else. As an educator, I'm responsible for them, as the kids that I'm seeing. It's all of that tied in together. It never stops. So it's like you're trying to get out of survival mode, but survival mode is continual. That responsibility of being for other people is just never stops. And then you have to figure out, what does that look like for you when it comes to being to enjoying life and pleasure. And then that hard question of, like, what do I want? What brings me joy? Nobody asked me that. Sometimes I barely have time to even say joy. I'm tired. A nap would bring me joy. Like, or healing for me looked like unlearning a lot of things, unlearning the shame, unlearning the guilt, unlearning the idea that my body was something to be feared, learning how to trust myself, learning how to trust somebody else, learning how to communicate. We talk a lot about, a lot of us have degrees or go to school, and, we learn the key things of how to communicate, but when it's time to put it in practice, it's not the easiest thing. Or even just how to set boundaries, because you're scared that, again, you know that you deserve love, but sometimes you take other things, and that's not even just with HIV, that's just a human thing. Sometimes you take more than what you deserve, and you let those boundaries go. So when I'm thinking about, I'm not just talking about pleasure, I'm talking more than sex. I'm talking about laughter, I'm talking about intimacy, I'm talking about feeling beautiful, feeling pretty, knowing that I am that girl, and actually applying that in real life. So when we talk about healing and we're talking about pleasure, all of that is what it encompasses, and it's a message that I have to keep telling myself, is that I deserve this. I deserve the connection. I deserve the pleasure. And lucky, I wouldn't say lucky, because today, I would say lucky today, because I actually like my husband, as we go into the next slide. Didn't like him 2 days ago, right? So I wouldn't say I was lucky, but that's a part of marriage. I would say that, I'm blessed and lucky enough to be with somebody that I never thought that I would be with, right? I never thought that having a child was something that is a thing. So I know right now it's normalized, where we can breastfeed our children and we can have a child. But I remember growing up where when that first person in clinic had a baby, it was like we all rallied together, like, how did you do it? Okay, tell me what happened. What were the steps? Because there was so many things of us being told that we couldn't have children. Nonetheless, now in 2026, we're breastfeeding our child, and that my body is not, my milk is no longer a harm to my child. Like that's something that I never thought that I would see as like dreaming. Yet here I am, I'm married, a mother, approaching 40, another thing that I didn't think that I would see. And thinking about aging in the future as a first generation, aging with, HIV, perinatal HIV, we're entering into spaces that no one expected us to reach. And we're writing chapters that many people never imagined that we would even have the opportunity to write. So it's a scary, but then also fulfilling thing when I think about marriage, motherhood, and midlife, because midlife is crazy for be 40 and then it's midlife. I thought midlife was 50, but apparently it's 40. So I'm entering into midlife. Yay, another thing to look forward to. But as we're talking about that, Kate, my experience is just one. And I know that as well, I'm not, I'm just one of many lifetime survivors, and they probably have similar experiences as we see in the chat. Are we a one size fits all group?
I don't think we are, Kim, and I just want to put that out there. There are some commonalities, but we've also got to recognize that HIV is a maturing epidemic, and lifetime survivors have lived through different HIV and treatment errors, sexual and reproductive health, comorbidity profiles, aging experiences. They're really going to differ substantially on when a person was born, what treatment they were initiated on, when they initiated that treatment, and what they were exposed to. So we've got to keep that in mind. I love thinking about the collective body of lifetime survivors, but also making sure we tailor to the needs of individuals too. So I'd like to kick it back to you before we get to the bigger group discussion. What do you want to see? What's ideal for sexual reproductive health for lifetime survivors?
So when I think about that, I think of one of the beautiful things about healing that gave me was the ability to dream again. Because it was a time when people didn't know what our futures would look like. So not being expected to fall in love, but pleasure and intimacy is something, having trauma-informed care, open conversations about sex, and not just at the clinic, but also within our own tribes together. Again, sex is something that is one of those, shh, don't talk about that, or don't talk about this makes me wet. This makes me feel good. This makes me feel hard. I know Amelia was talking about it with, we see those appendages rising, but nobody wants to talk about it. When even just in a conversation with one-on-one, people get nervous and get uncomfortable. And, let's start making the uncomfortable comfortable again, or at least start to make it comfortable. And I think that's one of the things that we really need to pull on and hope, right? We're in a space where the political climate is trash. Life sometimes gas is expensive. It's dropping a little bit. It ain't that much. It's still $70 to fill my truck, right? And again, I talk about chicken wings because if you know me, I love chicken wings. They're expensive, right? Everything is expensive in life, especially adding some kids, but adding a little bit of hope, especially as we're talking about how things are moving, that would be something that I would love for us to see, especially as we're approaching talking about more, research and integrating us into whole person care. Next slide. Even when we think about sexual and reproductive health of lifetime survivors, I really wish it was an inclusive conversation, non-judgmental, accessible. That accessibility, I feel like when I'm with my friends or my peers, like we do have these conversations, but to really have these conversations amplified into a setting where you have people you have organizations like the Well Project having this conversation where we have us as Dandelions coming together and kind of like kitchen room talk where we're like doing these conversations. Like, this is what it needs to be. It needs to be this. It needs to be providers saying, what does pleasure look like for you? And when them 15 minutes that like we meeting with them, I think that would be a dope conversation to have. One of the ways to improve even just sexual health is to make the services as integrated with holistic HIV care. And then thinking about when we focus on the pleasure rather than transmission and prevention tools, but really thinking about what does that whole person-centered care look like. The next slide. So we have reached the end, okay? But the three of us have spent a lot of time talking, okay? We like to hear a lot of your thoughts, your priorities around sexual and reproductive health for lifetime survivors, and your questions. So I'm gonna stop talking. I'm gonna shift it over to Bridgette, and Bridgette is gonna take us home. And thank you for being here and listening to us talk. Yeah.
I mean, y'all could keep talking because, not to toot my own horn, but I believe I said in the beginning that this was going to be a great conversation. And based on the chat, I was right.